So welcome everyone. Thank you for joining us today. So I'm Pastor Shannon. I'm one of the pastors here at Trinity, and so it's good to welcome you. I know all you guys, so it's good to have you with us today. We are here to continue our conversation about COVID-19 and what is happening in our community. If we have questions, Don led us in a discussion last month that was very helpful. So we're going to have Dr. Mandel help us today and talk to us a little bit today. So one of the things that I thought would be important to share with you is that we're a United Methodist congregation, and the United Methodist Church has a group of folks in leadership who have decided that they want to make COVID-19 vaccinations a missional priority. This is recognizing that this is a pandemic that affects everybody around the world, and there are a lot of places, even here in our community, but also around the world, that don't have access to vaccines the way that maybe some of us did. We got more people coming in. Thank you. So that's part of why it's so important for us to host this discussion in a church, even if it's not a faith-based discussion. So I just wanted to thank you all for being here, and we're going to have Don introduce Dr. Mandel for us.
There we go. Okay. Can everyone hear me? Okay. So it is indeed my pleasure tonight, my honor, to introduce our guest speaker this evening, who is Dr. Rachel Mandel. I met Dr. Mandel, who was trained in obstetrics and gynecology, several years ago at Frederick Memorial Hospital when we served together on what's referred to as the Institutional Review Board for Frederick Memorial Hospital. And it was just tonight that I learned a little bit more about Dr. Mandel's, not only her background, but also her responsibilities. And in summarizing that in a few words, I've been very impressed just in these few minutes of discussing with her the breadth of her technology, the breadth of her experience, working in the public health field, working with groups in our community, helping our local officials determine amounts of vaccine that's necessary for the public, working with other groups to see that the vaccination program is carried out effectively. And so I think that we couldn't find a much better person tonight to be the second in our series. Basically what I talked about was some of my knowledge about the virus itself. Dr. Mandel is going to be talking more about the problems, the way that we confront the virus through the use of vaccines in the public health of our community and probably throughout the state. So I welcome you, Dr. Mandel. Thank you.
Thank you, Don. I appreciate that. Thank you to Don. Thank you to Pastor. Thank you to Angela Spencer, who is my partner in crime on a lot of the things that I do. I just want to comment that Don did an amazing job when he did this talk last time in terms of laying out the basic science and really explaining what the virus is about, what the vaccines are about. I read through his 4 pages. I think it was 4 pages. Very detailed and very informative. So thank you. I appreciate laying that foundation. I figured that the best way to approach this, which is going to be very clinical in the sense that practical. What do you want to know? What do you need to know about what's going on, not only in the country, but in the county, in our community? What are we doing about it? And what do you need to know in terms of being able to get around, do your daily business, and be safe, which is really what we're all kind of interested in. So I'm going to start with talking about just a couple of statistics, a couple of facts at the national level. then we'll kind of bring it down to the Frederick County level, and then we'll just start talking about what's going on in the county and what's happening, and that you can be really proud of a lot of the efforts and initiatives that are ongoing. And then I may start to answer some of those questions that I'm pretty sure most of you have, but I really would love for you to ask questions as well. And again, I don't mind being interrupted. If something pops into your head based on what I'm saying, please stop me and we'll address it. And then we'll have some more time at the end to discuss those questions that you may have. So a statistic that I learned just today, which really shouldn't be such a surprise to all of us, is that 1 in 5 Americans have died from COVID. So think about that for a minute. I know we know the number of people who have died, over 600,000, almost 700,000, but when you put it in the context of the whole population of the country, and it comes out to 1 in 5. 1 in 5 is a lot, okay? So we need to remember that this thing, one, it's been pretty horrible. We're not done yet, unfortunately. The second thing that we need to think about now that's very topical are the children. 30% of new cases right now are in children across the country, 30%. And in terms of an increase in the percentage of children who are getting COVID, that number has increased 240% over the last couple of weeks. Some of that has to do with the Delta variant, some of that has to do with the kids going back to school, some of that just has to do with there are some locations in this country where the vaccination uptake rate just isn't that terrific, so the kids are getting sick. And this is important because, honestly, nobody wants any kid to get sick, right? So we know that there are about 400 kids, maybe a little less, over the course of this whole pandemic that have died from COVID. So I know that doesn't sound like a lot, but if it's yours, it's a lot, right? I mean, 600,000 compared to 400, kids shouldn't be dying from COVID. And especially since it's a preventable disease. Remember that, COVID is a preventable disease. The United States has spent in the last 3 months $5.7 billion on people with COVID, taking care of them, about $20,000 apiece, $20,000 apiece. It's a preventable disease. Okay, so I'll let that sit for a little bit, okay? Yeah, I know it's kind of depressing, but you have to know the facts in order to make decisions. Being informed is incredibly important. So let's move on to Frederick County. So Frederick County is a tough place to do this kind of a thing, to do vaccines because of the size of the county, right? In terms of acreage, we're the largest county in the state. So it's hard to get around, it's hard for people for transportation, but still, it needs to be taken care of. Currently, as of today, 62% of the total population of the county has been fully vaccinated. So that includes even the children who are not eligible yet. So 62% is not bad. If you take a look at just the people who are eligible, so 12 and above, that number is 75%, which is not bad. And if you look at the people above the age of 65, it's over 90%. Good job. Okay. So over the age of 65, over 90% of our population in Frederick County has been fully vaccinated. In terms of disparities and gaps, we're not doing too badly. If you take a look at proportion, for example, of population for Hispanic population, and then what percentage of the vaccines being given are being given to Hispanics, it's pretty close to even. Not bad. The same thing for Black, although I think we could do a little better with our Black population. White, we could do certainly a little better. We know geography-wise, we could do better in the northern part of the county and with some of the cities that are not right here in Frederick City. So we've got all kinds of data that helps us look at what's happening currently and then creating strategies to try and improve the outreach. When we talk about vaccinated versus unvaccinated people, I know that you hear a lot of information about who gets sick and who doesn't get sick. So let's try and bring that kind of local, all right? At Frederick Hospital, on any given day, given a certain number of people in the hospital, and most recently, I think yesterday, it was 37 or 36, about 67 or almost 70% of those people are unvaccinated, okay? And when you look at the ICU population, the intensive care unit population, and when you look at the people who may get intubated, have a breathing tube put down, and once that happens, their prognosis is not good. They're not going to do well. Those percentages are also very high in unvaccinated individuals. Meredith puts on their website a really nice graphic that anybody can look at that tells you what's going on in their hospital. So as of 2 days ago, I believe, they had 240 people in the hospital, 39 of them were COVID patients, about 87% of those were unvaccinated. When you look at the patients that were in the ICU, almost 87% of those were unvaccinated. And 2 days ago, when you looked at the 4 patients, the 4 COVID patients who had a breathing tube down, all of them were unvaccinated, okay? So the point is that the vaccine may not be perfect. It's pretty darn good. When we think about the flu shot that we expect on a good year for the flu shot, it works 30, 40% of the time, but these vaccines work 80, 85, 90% of the time at protecting you against getting the virus, but it's not perfect. But what it does do is it helps prevent you against getting serious disease, ending up in the hospital, being in the intensive care unit, having to get a tube put down your throat so that you can breathe. It does a really good job at that. So, we really have to kind of keep that in mind. Again, not perfect, but pretty good. Okay? I get asked this question a lot. Well, if I'm going to get COVID anyway, why should I bother getting the vaccine? A lot of people are like that. They're like, well, people with vaccine get COVID. So if I'm going to get COVID anyway, why should I bother getting the vaccine? I look at it like this. It's like a seatbelt. You get in a car and you put on your seatbelt, which is, by the way, the law. Okay? It's a public health guideline and law that you have to wear a seatbelt in your car. So this is not something that we are unfamiliar with. We're actually familiar with doing things in the best interest of public health. But you get in the car, it doesn't stop you, the seatbelt, from getting in an accident. But what it does is it decreases the chance that you would have a serious illness or die in that accident. The vaccine does exactly the same thing for you. It's your seatbelt. It may not stop you from getting COVID, but it certainly is going to make a difference in terms of whether you get seriously ill or whether you end up in the intensive care unit and have to have a tube for breathing. So when you talk to people about that, just kind of think about it in that context. It's not perfect, but it's really a good aid for us. It's really helpful. Any questions so far? Okay, good. I've overwhelmed you. That was my goal. That's good. Okay. So what are we doing here in the county? Do we have any questions there?
Not yet.
Okay, good. So in the county, we don't call it a task force, but it is a task force. It's a collaboration of people from the major vaccinating organizations in the county. The hospital, the health department, the city health clinic, FCAA, community-based organizations, nonprofits who have footprints out in the community, especially in those areas where there are minorities or marginalized or underserved or underinsured populations. And this group meets on a weekly basis. Initially, it was even more frequently than that, discussing what's the strategy, where do we need to be, who do we need to talk to, how are the vaccinations going. It's an ongoing, continuously improving process because we're talking every week about what happened last week, what's coming up this week, where is everybody going to be? Everybody's going to cover everybody. If the hospital is typically working with, let's say, the Asian American Center on setting up pop-up clinics, and the hospital has a shortage of nurses, then the health department may step in, and vice versa. So everybody's supportive of one another. They work off a common spreadsheet with all the clinics and all the staffing, and even community health workers. Community health workers are individuals who have special training to go out into the community to help people get services and to understand what they can do to make themselves be healthier. A lot of these community health workers live in the communities that we're interested in. They may be bilingual. So the community health workers are attached to these pop-up clinics as well. The hospital just got a new mobile van. I was just out at the Frederick Town Mall parking lot on Monday for Mondays on the Mile with the health department. And they've got a really sweet setup there where they use one of the electric buses the cities let them use. So you can go into the bus, you do your paperwork and everything on the outside, but then you go into the bus to get your vaccine, and then you can sit inside for 15 minutes after your vaccine, and it's air conditioned. So that's really nice. It's a nice setup. But that's the kind of thing that's happening. There's these clinics are being set up all over the place. Angela was with a team in the streets on Saturday. We've got, fall's coming. We got all kinds of events in Frederick County coming up. There's going to be people there with education and vaccine clinics from these groups ready to engage the community and to make sure that they have the information that they need so they can make a decision that works for them and for their family.
There is a question.
Yeah.
So they're wondering about boosters, if you can talk a little bit about boosters.
Sure. So before I talk about boosters, I want to clarify a little bit of language. You've probably heard two different things. You've heard third shot and you've heard booster. They're the same, but they're not really the same, okay? They're the same because it's the same vaccine. There's no change. Pfizer is Pfizer, Moderna is Moderna, Johnson & Johnson is the same. It's the same dosage. But the reason why they're given is different, and that's the difference in terminology. A third shot is given to somebody who we don't think has gotten their best response from their initial injections. It might be somebody whose immune system is not working well and maybe did not respond as robustly as well as we would have liked. So they get vaccinated, their immune response is here. We'd like to see it here, okay? So it's here because of maybe medication that they're taking, or maybe they've got a medical problem that interferes, or they've had chemotherapy, or they've had cancer. There's a whole list of conditions that may put them in that category where their body just didn't respond to the vaccine as well as we would have liked. So they're here, we give them a third shot, and then they're here, where we want them to be, which is where most people are. You give them 2 shots, they're up here. The booster is meant for somebody who got a great response and did exactly what they were supposed to do at the beginning from the regular course of the vaccine. And over time, they start to lose a little bit of immunity. So the point is to give them a booster to get them back up again. Again, this is another concept that we're pretty familiar with, right? We've all had boosters at one point or another in our lives. We get tetanus boosters. I just recently got a pertussis booster because we have a new baby in the family. So we're all used to the concept of a booster. You've been immunized at one point, got a good response, but over time, that immunity may decrease, and we want to bump it back up again. So difference between third shot and booster. We are not giving any boosters right now. We are only giving third shots. You do not need a doctor's note or a prescription to get a third shot. All you have to do, if you go to, let's say, Oak Street, where the health department has their standing clinic, and you walk in, all you have to do is just check the box that says, yep, I'm somebody with a crappy immune system, I want a third shot, and they will give it to you, okay? So, and there's a whole lot of reasons, and if you're not sure if that's for you, if you're not sure you're in that category, talk to your doctor about it and see what they think. We've actually, in general, the medical community's been pretty liberal about this kind of thing, because what's the point of saying somebody can't get another shot if you think that they might not be getting a good response? You want them to be protected. So third shot, booster, same but different. Okay. The next question then is, are we going to get boosters? I suspect, and this is just my personal opinion, that at some point it will be recommended that we all get boosters. They may start with rolling it out like they did the original vaccine based on at-risk populations. Maybe people in congregate living, nursing homes, assisted living, et cetera. Maybe first responders, maybe healthcare workers. But eventually, I think everybody's going to get a booster. This business about 6 months, 3 months, 8 months, a lot of that is artificial in the sense that until we look at the data, we're not going to really know for sure, and even then, what the right time frame is for that kind of a thing for a booster. But I suspect that we will get a booster. Will we be getting COVID shots for the rest of our lives? That's hard to know. Probably. We get flu shots every year. Again, not something we're unfamiliar with. There's a different flu strain or similar strains every year that we make a vaccine for. The same kind of thing can happen with COVID. There may be different strains or variants of COVID that arise over the course of time. What's nice about these mRNA vaccines is that you can tweak them fairly easily, certainly compared to other kinds of vaccines we've used in the past, and kind of customize them to the virus that you're trying to treat. So we may find that we have boosters. Maybe it's not the exact vaccine we've had this time, but there probably will be boosters and we probably will be getting them on a fairly regular basis. Have no idea what that timeline is. Again, the really fun thing and the really frustrating thing about science is that you're always getting new information, and you get that new information and you make the best decision you can based on it, and as you learn more information, then sometimes you have to change what you're doing and pivot. So we're just going to have to wait and see how this plays out based on what the science is telling us. Yes? I can repeat your question, Don?
Okay. Well, I want everybody to hear that, okay?
Sure.
So let's make the assumption that sooner or later we're going to need a booster. Is that booster going to be based on, let's say, collective scientific data that says the average person's titer against COVID has decreased to a point where that booster is necessary?
That's a really great question. So what Don is asking is, what's going to go into that decision-making process about when to give the booster and who to give the booster to? I suspect, but I don't know, that we're just going to make some generalizations based on the research that's being done in specific populations. Just like they did when they looked at the original vaccine and how effective it was in the original studies. You take a population of people and you research them and you study them and you draw their blood and you look at them, and then you kind of make some assumptions based on what they're doing and you apply it to the rest of the population. And then you move forward. So I don't think that they're going to be doing any kind of blood work. It doesn't make sense logistically. It doesn't make sense financially. And they're going to do this research like all the countries are doing, like Israel's doing, like United Kingdom is doing, and they're going to follow populations of people and then make recommendations based on that. Yeah, it doesn't make a lot of sense to try and figure out. And we don't even know, to tell you the truth, if somebody gets their blood tested and it says that they have a certain antibody level, and antibodies are those cells that are in your body, those chemicals that help protect against the infection, we don't know what level is the right level. In any particular person, we don't know what that is. So it's really hard to make a decision based on that number because there's so many variables, there's so many factors that makes my immune system good or bad compared to the person standing next to me. So they do the best they can, making those recommendations based on the data that they have. Did that answer your question okay? Okay. Angela?
So you just mentioned antibodies, and this past weekend in the street, I had a conversation with a person who is not been vaccinated, okay? And basically they're not planning to be vaccinated, but they said they went to their doctor and had their blood, whatever, tested to determine if they had the antibody. And this person told me that their body was just swarming with tons of antibodies.
Okay.
How does that happen? I mean, do you have a symptom or a feeling in your body that says, oh, I have the antibody? How do you get blood tested? How do you know? And how does that even happen?
So the question is, how does somebody know if they have antibodies? Because she ran across somebody who has not been vaccinated and went and got tested for antibodies, and they had antibodies already in their blood. That person's had COVID. They just didn't know that they had it. Okay, so, and that happens. You can have people who don't have any symptoms and they have COVID. And that's one of the things that makes it so dangerous, because just because you don't have symptoms doesn't mean you can't give it to somebody else. Okay, so that's the reason, and we can get into masks as well. That's part of the reason for wearing masks, and that's part of the reason, even if you're vaccinated, why you may still want to wear a mask in terms of protecting not only yourself, but other people around you who may or may not be vaccinated. So the answer to that question is, yes, you can get tested to look for antibodies, and if you have antibodies, that tells us that you probably had COVID already. Now, the next step after that is, well, I've had COVID already. I don't need to be vaccinated. And, you know, I've heard that a lot. Unfortunately, I wish it were true. I wish that's all that needed to happen, because then we'd have a lot of people in this country who had COVID who didn't need to get vaccinated and would be immune. But that's not the way it works. The studies are showing right now that the immunity from the vaccine is way better than it is from natural immunity from having COVID yourself. That you're probably okay through the first 3 months. But then after that, it really starts to drop off. And on top of that, your immunity was to a particular type or a particular flavor of COVID, which may not be the kind of COVID that you get infected with the next time. So we've all heard Delta variant. That's the most common variant right now in the United States. Right now, 99% of new cases are Delta variant, 99% of them. But there are variants being made all the time. Viruses are incredibly smart. I'm giving them credit by saying that they're smart, like they think, they don't think. But this is just the way nature is. They keep changing and mutating to find the best possible virus for infecting the host. The best possible virus. And the more virus that is created, the more we allow this virus to replicate and to reproduce, the greater the chance. It's just statistics. The greater the chance that we're going to come across a variant of that virus that's worse than what we currently have now. It's just a matter of time. So is it possible that for everybody that's been vaccinated so far, and the vaccine has been doing okay against the Delta variant, grateful for that, right? But we don't know if there's going to be another variant that's going to come along that this vaccine is not going to work against, or not as well, and then we're back to square one for everybody. So really, that's another reason for people to get vaccinated, is to decrease the opportunities for this virus to reproduce and perhaps create another form of itself that's worse than the ones that came before. So there's all kinds of reasons for vaccination. The decision to be vaccinated is not an easy one. I mean, people struggle with it, and I certainly understand why that is. People worry about a whole number of reasons why this is not a good idea. They worry about how quickly the vaccine was produced. And if you would indulge me for a moment, I'd like to explain that a little bit. So maybe you could also talk to some people that you know who may be asking the same question. So the typical process for vaccines, for creation of vaccine, it's a long process. There's no doubt about that. Done, it's like 3, 4 years, 10 years. It's a long process, right? The technology for mRNA has been around for 20 years. So it's not like that was brand new. That's actually been around. This is a vaccine method in search of an infection to use it on. They've tried using it for all kinds of things. They tried using it for Ebola. They tried using it for the common cold. They tried using it. It just wasn't working. For whatever reason, it worked for COVID. So that technology that is in this mRNA virus is not new. Again, 20 years it's been around. They've been working with it with 20 years. So normally the process is you're creating a vaccine. You work on creating the vaccine. You put together a research study. You have to gather 30 or 40,000 people in this research study that you're going to watch them over a certain period of time to see if the vaccine worked or not. And then after you do that, and you write your paper, and you explain what happened, then you put it before the FDA, and that takes a long time. And there's a lot of discussing about whether it works or not. And in the meantime, you're not making any vaccine, right? There's no point in you making any vaccine because you don't know if it's going to be approved. It's wasted money. So no vaccine gets made. So you go through that whole process. And if, and only then, if the FDA approves your vaccine, then you start to make vaccine. Then you have to figure out, market it, and get it out to the community, and get to doctors, and get to other people, and explain what this vaccine does, and then get it out and get it working. That's a long process. So let's think a minute about what happened this time. What happened with COVID? First of all, mRNA, it's been around for 20 years, okay? Not brand new. So how much, well, let me back up a little bit. Who was focusing on creating this vaccine? Who was paying attention to this vaccine and working on this vaccine for COVID? Everybody. Anybody who had a lab that was working on vaccines or working on this type of virus, all of a sudden, they might have been working on this, all of a sudden, we're working on COVID, okay? So there was an incredible amount of focus on creating a vaccine all over the world, the entire scientific community. That's a lot of brain power. How much money got pumped into development of this vaccine? Endless. An incredible amount of money into the vaccine. Never seen it before in anybody's lifetime. Anything you need, we'll give it to you. Incredible amount of money. Okay. How long do you think it took them to gather 30 or 40,000 people for a research study? Okay. Took no time at all. Everybody wanted to help. Everybody wanted to volunteer. Heck, I volunteered. Okay, they didn't take me, but I volunteered. Took no time at all to get 30, 40,000 people. Okay. At the same time all this is going on, they're making vaccine. They're not supposed to be making vaccine. That's not how we normally do it. Why were they able to start producing vaccine? Because the government paid for it. They took no financial risk. The government's still paying for it. Vaccines are free, okay? Nobody has to pay for a vaccine. So the government paid them to make the vaccine while they were doing the research studies. Things happened at the same time. Never happened before. Okay. So then you've got a vaccine. We're making vaccine. We're hoping that, it's going to work. We're researching it at the same time. We've got our 40,000 people. And what you're looking for is it working? Out in the community, is it going to work? Now, if you're working on a vaccine or a new medication, it's possible that whatever thing you're trying to treat, whatever illness you're trying to treat, may not be that common. It may take you a long time to have enough cases, enough exposure, enough data to know whether your product is working or not. How common was COVID? It was everywhere. It didn't take them any time at all after starting the vaccine studies for those 30 or 40,000 people for that data to tell them whether it was going to work or not, because COVID was everywhere. People were getting sick left and right, and the people who were vaccinated were not. Okay, so all of a sudden you take a process that's this long, and you take all these factors, and all of a sudden the process is this long. That's why it seemed like it was really fast. We just all really focused and put resources into it and did what we had to do to get to this place. And I'll be honest with you, given that we're so kind of lackadaisical about flu being 30 or 40%, that's a good year, 30 or 40% effective, and then getting a vaccine that is 85 or 90% effective, that's just unbelievable. As bad as this has been, could have been a whole lot worse. The vaccine is really effective and very safe. So we're going to talk a little bit about safety. Any questions first before I move on? Yes?
Before you go too far away from the statistics, has there been any attempt to clean up the numbers of fatalities of those who died from COVID and those who died with COVID but from something else?
Right.
So it seems that those numbers are lumped together.
Sure. So the question is, has there been any attempt to clean up some of the data related to people who have died from COVID and people who might have died from something else along with COVID? The problem is, I wish they would, I wish they could. The problem is that the coding systems for this kind of thing are not meant for this. It's not meant to have that level of detail. And from somebody who has signed death certificates before and looked at the categories that were acceptable, and I didn't feel that they had any relationship whatsoever to what actually happened with the patient, it's a frustrating problem. Okay, so some of it really is truly documentation. Some of it is clinical. Some of it is, it's sometimes hard to separate those two things out. If you've got somebody, for example, with congestive heart failure or COPD, so that puts them at higher risk of complications with COVID, and they end up dying. Is it just the COVID, or are they at higher risk? Was it COVID and their COPD or the congestive heart failure? So sometimes it's more than one thing, but it is very frustrating. I agree with you, 100%. Yeah, so they're going to do their best. In retrospect, they may be able to clean some of that up, and going forward, they may be able to make it a little more specific. There was kind of a fog of war at the very beginning, with so many people dying and people not really understanding the disease as well as we understand it now, and even that's not as well as we could, but we're making progress. So I appreciate the question, though, because it is frustrating. Does that help? A little. Okay, all right. It's the best I can do right now. In terms of data, what do we know, and the effectiveness and what we don't know? We know what we know, and I'm not sure that we know what we don't know. Okay, so what I can tell you is there are some things that we know. We know how effective it is. We know that, certainly at the beginning, that the vaccine was 90% effective from stopping you personally from getting COVID. And it decreased your risk almost 100% of ending up getting severely ill, ending in the hospital, and being in the ICU. That was pretty good. We knew that. From the standpoint of pregnant people, pregnant women, and their risks, I'll be honest, as an OBGYN, we don't know really long-term, for sure, effects or lack of effects. We understand the science. We don't believe that there's going to be any long-term effects because the vaccine is gone from your body within 3 days after getting the vaccine. It does not change your DNA. It does not change your genetics. That's not how it works. But can I tell you 100% that we know everything about the vaccine in relationship to that? No, I can't tell you that. What I can tell you is that we know from the large number of pregnant women who have taken the vaccine that their statistics are no different from their pregnancy outcomes than the baseline population. And that's a really important thing to remember. You have to look at it from the baseline population. There's always going to be some problem. There's always going to be something that's going to happen. Somebody's going to always have a complication. But was it worse because they got the vaccine? And if you think about it, we've given hundreds of millions of doses in this country. Tens of millions, if not billions of dosages across the world. Don't you think that if there were truly a complication or a problem of any significance from the vaccine, that we would know, just based on volume alone? You don't really hear anything, do you? You hear anecdotal stories, again, which you don't really know if that person would have had that problem anyway, even without the vaccine. So from the standpoint of pregnancy, when you're looking at, because we've got a pretty good population of women who, one, took the vaccine early on because they really felt their risk of getting COVID was too high not to. Healthcare workers were really the biggest group, but there were also a lot of women who got vaccinated who didn't know they were pregnant at the time. And then, of course, there were women who knew they were pregnant and decided to get the vaccine. In these cohorts of women, and of course, as we're moving along, we learn more and more about it, there was no increased risk of miscarriage, pregnancy complications, problems with the newborns, preterm labor, infections, infertility, none of that. Everybody fell right in the middle of the range for what we consider baseline numbers. Nothing out of the ordinary, nothing crazy. Now, what we do know, and again, remember, I'm talking about things we know and things we don't know. What we do know is that a woman who's pregnant, who is unvaccinated and gets COVID, will do a whole lot worse than a woman who is pregnant and is definitely vaccinated. This person who's vaccinated may get sick, may not feel well, might end up in the hospital, but her chances of ending up in the ICU, having a tube put in for breathing, losing her baby, or having a complication are way less than this woman who is unvaccinated. And we know that that's a significant difference. Pregnancy is not easy to start with. Pregnancy is a high-risk situation. There are a lot of changes in a pregnant woman's body that put her at higher risk if she gets COVID of getting seriously ill. That we do know, yes?
Yeah, it makes sense that the mothers would react that way, but what about the effect of the vaccine on the fetus?
Okay, so the question is, we know it makes sense that the mothers react that way, but what about the impact on the fetus? So that was my next step. That was the next place I was going to. So the placenta is a really, really great organ. The placenta is a great filter. It's a great protector for the baby. Baby gets nutrients, of course, through the umbilical cord. So what happens? The vaccine does not go into the umbilical cord. Remember, it clears out from the body after 3 days. Basically, you get the vaccine, it dumps its information to your body. Your body starts making those antibodies against the virus, and then your body clears the vaccine out of your body. Never gets to the placenta. What does happen, and this is one of the things that we know, okay, is that those antibodies cross the placenta, go through the umbilical cord, and go to the baby. That's a good thing, okay? And this happens all the time with women, as they have an infection or they get a vaccination, and those antibodies go through the umbilical cord, and the baby is born with what we call passive immunity, meaning they just happen to be there, and the antibodies came by. Not that they had the infection, not that they got vaccinated, they just got the benefit of those antibodies because they were, in utero. Now, we don't really know the significance of that. We don't know how long that immunity is. We don't know how good that immunity is. But I'll be honest, from my perspective, it's better than nothing. Okay? Then there's breastfeeding. Breastfeeding is a similar kind of scenario, is that you don't pass the virus through the breast milk, you don't pass the vaccine through the breast milk, but you can pass the antibodies, which is another reason why we always encourage breastfeeding, because the babies get that passive immunity, the newborns, against a whole lot of things that the mother might have circulating to protect her. So if you've got a mother who's vaccinated and she's breastfeeding, her antibodies will pass to the baby, to the newborn. So why is that important? Well, the newborn can't get vaccinated, right? So if you can give them any kind of protection, that's important. You want to do that. That's something we know. Again, we want to kind of keep in mind what we know and what we don't know. These are things we know. Yeah, Don.
You and I talked a little bit before about what sort of strain it's putting on the Frederick Hospital and the care in Frederick as a result of people not getting vaccinated and contracting COVID.
Sure. So the question is, what kind of a strain is it putting on the healthcare system, specifically Frederick, related to people who are unvaccinated? I can tell you that, and this is not just for Frederick, but you see it in the news, it's all throughout the entire country. Our healthcare workers are overwhelmed and they're stressed. And resources are tight, and intensive care beds are tight. And as you and I talked about, it isn't so much the bed or the space, it's the staff. Do we have enough nurses? Do we have enough staff, respiratory therapists, et cetera, to take care of these patients who are very, very labor intensive? And appropriately so. So that kind of goes back to the original statistic that I gave at the beginning of $57 billion in the last 3 months on COVID patients, the greatest majority of which was unvaccinated patients. So would vaccinations help decrease the load and the stress and strain on our healthcare system? Without a doubt. Without a doubt. I mean, it's amazing to me how the healthcare workers are just still dug in and doing their jobs. There's going to be some who are going to quit after this. When things settle down and they really get their wits about them and they say, I'm not interested in doing this anymore, they will quit. There'll be doctors and nurses and all kinds of people. You're going to see, I think, you're going to see an efflux of people out of healthcare. But they've done an incredible job. And, you just take a look at what's happening in some of the states that are under-vaccinated, how much they're struggling with beds and resources and having trouble finding any kind of bed for people who don't even have COVID, right? So if you have a heart attack or you're having cancer or you need treatment for something else and you need a bed at the hospital, you may have trouble finding one because it's filled with somebody who's got COVID. Chances are pretty good statistically that they're unvaccinated. So really that decision, and it's going to be just a tiny political here, just forgive me. But all of those people who say, this is my right, this is my autonomy, I don't want to get vaccinated, you can't make me. The bottom line is, it's not just them. It's really everybody else as well, for a whole lot of reasons. So for the same reason why we don't smoke in certain places, it's not good for all of us. So this is a similar kind of a thing. The vaccination is not just for that person. So let's talk a little bit about masks, okay? The mask is not just for the person wearing the mask. The mask is for the other people around you. You don't know their vaccine status. By wearing a mask, you are doing a public service. Thank you for wearing your mask. I appreciate it, okay? I'm vaccinated. I'm pretty comfortable in my vaccination status, but I appreciate the fact that many of you, almost all of you in this room, are wearing masks, because that tells me that not only do you care about yourself, but you care about other people as well. This is the thing that I struggle with the kids. It's not complicated, at least from a science standpoint, from a scientist and a doctor standpoint. You want to keep your kids healthy. We do what's called ring vaccination. You've got a kid who can't get vaccinated. So what do? You vaccinate everybody around them. You ring them with people who are vaccinated. So that'll decrease the chance that kid will get sick. You don't want to vaccinate yourself because you don't care what happens to your kid? That doesn't make any sense to me. We vaccinate our kids to go to school. Again, we're used to this. It's not any different. It really isn't any different. The mask is difficult because we were told at one point, if you're vaccinated, you don't need to wear a mask. Again, science changes, and we have to kind of roll with it sometimes. So what I tell people is you have to look at the situation that you're in. If you're outdoors and you're vaccinated, and it's a pretty day out, and there's a little bit of a breeze, and you're not around a whole ton of people, do you need to wear a mask? Probably not. If you're with people you know and they're all vaccinated, you're at a picnic, probably not. Your risk is really small. If you're at one of those football games this past weekend, where they had 50 or 70,000 people in a stadium, and you had no idea what their vaccination status was, and nobody was wearing masks, it was outdoors, I'd be wearing a mask, or I wouldn't be going there, okay? If you're with a kid who's not vaccinated, because they can't be, and you're someplace that you still think that you don't need to wear a mask, would it be a good idea to wear a mask to set an example? Maybe. So it's really important to think about every circumstance that you're in, and then think about what's in not only your best interest, but the people around you, because you care about the people around you. I still don't go and eat indoors. Could I? I could. I could find some place. Do I feel comfortable with it yet? Not quite. I'm not quite there yet. That's my choice. You know, I will not begrudge somebody if they want to go eat indoors. They're wearing a mask. They take it off when they're eating. They've been vaccinated. They're sitting maybe at a table in a corner. That's their choice. But that's not a decision I'm going to make for myself or my family. So you have to kind of think about that in that context.
There are a couple of questions here that kind of relate to that. So one, it isn't about masking, but it's about testing. So what does it say? If we could have COVID and not know it, how often should we be tested? And then the other question was back to the vaccine conversation. Are you aware of anyone dying from the vaccine?
Okay. I am not aware of anybody dying from the vaccine. That doesn't mean that it hasn't happened. Again, it comes back to that issue of tens of millions of vaccines given, hundreds of millions, maybe billions of vaccine given. It just isn't happening, okay? You know, people who have allergies, actually, we thought initially this might be a problem with this vaccine. It has not been a problem. You know, serious allergies, anaphylaxis, carry around an EpiPen. That's kind of the criteria that really most people have been using. Do you have an EpiPen? Have you ever had to use it? Okay, you need to sit for 30 minutes instead of 15 minutes. Hasn't been a problem. Just hasn't been a problem. And the other question had to do with, I'm sorry.
The other question was about testing.
Testing.
How often would you
Yeah, testing, again, it's another one of those things where you have to use your common sense. Why are you getting testing? If you're traveling and you need to get tested before you go, get tested. If you're visiting somebody that is at risk for getting COVID, they've got, you know, medical problems, and you're concerned that you've been exposed to some people maybe who weren't vaccinated, or you've been in a large group, you should probably get tested. If you're, when you're coming back from traveling, coming back to your family, you probably should get tested. If there are a lot of organizations that if they're requiring vaccinations, they may, if you don't want to get vaccinated, you need to get tested once or twice a week, and that's a circumstance for testing. You know, the testing is free right now still. This is still an opportunity to have liberal use of the testing. For example, I was someplace where I was talking to some people. I was over at near Frederick Town Mall at this Mondays on the Mile, and they were doing testing there, and there was nobody in the testing line. There was nobody in the testing line. And I was around a lot of people that I think most of them were vaccinated last week for a couple of days at a retreat. And I'm going to be visiting with a newborn in my family, my great niece, in a couple of days. I decided to get tested, just to be sure, okay? So you've got to think about your circumstances. Certainly if you don't feel well, you need to get tested. I mean, there's so many opportunities, so many places you can get tested. It's pretty easy to do. Now, that brings me back to the positivity rate, which I did want to talk about. The positivity rate is that percentage of people who get tested and turn up with a positive test, okay? It's not a perfect number. And what I mean by that is it kind of gives you an idea how much virus there may be in the community, but you know, whether it's 5.4 or 5.5 doesn't really matter, because think about this, it's a percentage. If 100 people get tested because they're nervous about Delta and 5 of them are positive, that's different. That's a different rate than if 200 people get tested because they're really nervous about Delta and only 5 of them, those same 5 people, are positive, okay? It artificially makes you feel better if more people are getting tested but don't have disease. It makes you feel better if the number's lower. It doesn't really mean anything. It's just kind of a broad idea. Initially, we were using it as a cutoff number for when kids could go back to school. Do you remember that early on? It was like, oh, if you get below 5% positivity, the kids, it's safe for them to go back to school. We realize now that it probably doesn't mean as much as we thought it did. It really is just a function of how many people are getting tested. If there's a lot of virus in the community, yeah, the number's going to be higher. If there's less, the number's going to be lower. But again, that day-to-day shift really doesn't mean anything. So you can go on the website, the health department. You can take a look at all the data that's on there. You can look at how many people have been vaccinated. You can take a look at what the positivity rate is. You can look at hospitalizations. You can look at the breakdown by age, by gender, by race and ethnicity. All of that stuff's at your fingertips in general from the county. What I'll tell you, though, is that we don't know really how many people in the county have been vaccinated completely because, for example, people in the northern part of the county may be going to Pennsylvania to get vaccinated because it's easier. And we don't have a technology or a sharing arrangement with Pennsylvania to know who those people are. So those are just kind of some of the challenges that we just don't have that sharing process in place to have the big picture, the whole picture of Frederick County residents. We're doing okay. Angela, where are we in terms of in the state? How are we doing percentage-wise?
Actually, there's a data source called CRISP, C-R-I-S-P, that
CRISP.
computes all of our information, race,
Correct.
gender, so forth. And as far as Frederick County, last week, well, September,
We're fourth or fifth in the state, aren't we?
Fourth or fifth in the state.
Doing best. We're the fourth or fifth best in terms of vaccinations for our population in the state.
But a couple of weeks ago, Frederick County was number one.
Yeah, we're slackers. A couple of weeks ago, we were number one. Now we're only fourth or fifth. But there were 24 jurisdictions, and they're being followed in this CRISP database, which is Chesapeake Regional Information System for our patients, which collects a lot of data across the state, which was very useful for following this kind of thing. So, other questions or comments? Yes?
When you're tested, is it going to tell you if you have the original or the Delta?
Great question. She wants to know if you're tested, will it tell you if you have the original or the Delta or the Mu, which is the latest one that we're looking at, not unless they test for that specifically. Okay? So they will just tell you that you're positive or negative, but a certain percentage of those tests will be sent on for further testing, especially the positives, of course the positives, to determine which variant it is. Not all of them, but they're going to get a sample so that we know it's in the community. So, and that's not something that you could ask for, but you don't have to pay for it, so it doesn't matter. It's really for scientific purposes and for public health reasons. Don?
In the early days of testing, let's just say 6 months ago, there were a number of false positives. Do you think that the efficacy of the testing has improved?
Okay, so the question is, has the testing improved? That early on there was a lot of talk about false positives or false negatives. Yes, the testing has definitely improved. We've learned which tests are the best tests, and it's gotten easier because there isn't as much pressure. We've got more resources. There isn't as much pressure to do as many tests as we can in whatever ways we can. Some of the rapid tests that were done were less accurate. The PCR test, which is the one that they put in your nose and stick up into your brain, that one's pretty accurate. And that's the one that most people are going with now. Again, if you had a significant concern, and I was kidding about them putting it in your brain, it only goes in your nose, it just feels like it's going into your brain. Okay. But they're getting better at that. Now, actually, they don't even go in far. They just kind of go in the outside part of the nose on both sides. It's a little more comfortable, but it's never going to be great. So the testing that we used to do, the quick testing, you can use it still in some circumstances. If you've really got kind of an urgent situation, it might give you a clue about how you're doing. I would trust the positive, to tell you the truth, more than I would trust the negative. But at least it gives you an idea. But the PCR, which is the swab, the nasal swab, is typically what most people are doing because it's the most reliable. We've gotten better at it. There's no doubt about that. Yes.
So you've talked a lot about the mRNA vaccine and these the 3 shots or the booster, but some of us had J&J, and talking about the vaccine and the risks for the vaccine, and
Right.
J&J and AstraZeneca do have more risks or have in this whole, so I was wondering if you could talk a little bit about that.
Sure. So we don't use AstraZeneca here in the United States. We do have it in the United States, but we're not using it. We have plenty of the other 3. And I believe we're probably shipping most of the AstraZeneca to other countries. The J&J is a really good vaccine in the sense that it's easy because it's one shot. There are a lot of populations or a lot of people that's what they prefer. For example, transient populations, homeless, incarcerated. There's a whole lot of reasons why one shot makes sense. It is a different platform. It's different than the mRNA. It's something that we're familiar with. It's something that's been used in other vaccines. And I know there was a lot of fuss about blood clot risk. The truth of the matter is that the risk of getting a blood clot is about 1 in a million, literally 1 in a million. And when you think about it, your risk of getting hit by lightning is 1 in 500,000. Is 1 in 500,000. So your risk of getting hit by lightning is half the risk of getting a blood clot with the J&J vaccine. Now, again, having said that, if it's you, it's important. So you have to decide how to work that. Now, women who are pregnant have a slightly increased risk of getting blood clots because they're pregnant. It's just part of one of those risks of pregnancy. If I were going to make a choice between vaccines for a pregnant woman, I probably would say get Pfizer or get Moderna. Stay away from J&J. Not that I'm worried about it, but why take that risk? Let's be cautious. If you have a medical condition that predisposes you to blood clots, I would say the same thing to you. Take one of the other vaccines. We've got plenty. Why take that risk? But it's an effective vaccine. It's a safe vaccine. And we'll be seeing soon whether people will be getting boosters. We'll also be finding out whether it'll be okay to mix and match. We don't know the answer to that yet. I suspect the answer is going to be yes, because an antibody against COVID is an antibody against COVID. It doesn't matter where it came from, because it's your body that's making it. But again, we'll have to get that guidance to tell us whether we can do that or not. But there is plenty of vaccine, which is nice, because that wasn't always the case. Okay.
We have at least one more question here.
Okay.
And it's 8 o'clock, so we don't want to keep you too long. But the question is about your opinion on domestic and foreign travel during these COVID days.
Okay. That's another one, domestic or foreign travel. That's another one of those questions where you have to look at your particular situation and what your risk tolerance is. There are a lot of countries, there are a lot of states where I would not travel at this time. I wouldn't go to Florida. I wouldn't go to Texas. I wouldn't go, well, I'd like to go to Hawaii, but I don't know if I'd go right now. You have to look at what the prevalence, what the amount of virus in that state or that area is, and also decide what are you going to do when you get there. You go in some place where there are a lot of people that might not be vaccinated, or you're going in a camper van and it's just going to be you and your significant other, and you've got your own little bubble, and you're going to be out in Teton National Park in the middle of nowhere with nobody else. That's probably okay. When you take a look at traveling overseas, I think you have to take a look at the same things. Where are you going? Why are you going? Who are you going to be with? What are you doing when you get there? And how much risk are you willing to take? I like cruises. Would I get on a cruise boat now? Nope. Just we haven't sorted out, the safety issues for cruises at this point. Just at least not enough to probably a lot of people's satisfaction. People seem to be doing okay in airplanes, but I get a little more concerned about the airport in terms of exposure and people, who it may not be as ventilated, and you don't know their vaccine status. And again, where are you going? What's the rate of the virus there? How are people handling it there? And what are you going to do when you get there? There is no one answer for these kinds of questions. And Don and I were talking earlier about what happens here in the church. What are you guys going to make decisions about choir and about other activities here? You've got to take a look at what you're doing, what your congregants feel about it, what's the circumstance, how much risk are you willing to take, and then how are you going to pivot if something changes? Because information's always changing. Recommendations are changing. It's just the way it is. We can do this, though. I have no doubt that we can do this. But everybody's got to work at it.
Well, thank you so much. We so appreciate you coming and joining us. We're going to have this on YouTube as well. So if folks, want to share how great this conversation was, so other people can catch up on it too, or if you get a question that we talked about tonight and you can't remember exactly what the answer is, you can always come back to this conversation or to Don's as well if you have some of those technical questions about the virus too. We thank you for joining us, and stay dry because I hear some rain.
I hear a lot of rain.
Yeah.
Pastor, is it okay if they think of another question, if they send it to you and you can send it to me?
Sure. So if you think of a question, folks online, you can email me. My email is on our website. So seniorpastor@trinityfrederick.org. So you're welcome to email that to me, and I will pass that along to Dr. Mandel, and we will get you the answer to that. But thank you so much.
Thank you.
I very much appreciate it. Good night, everybody.